All right. If I can get everybody to convene. So welcome. Good afternoon, everybody. For those who I don't know and those who are live streaming, I'm Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health. So today is one of our public health fora, which is one of a series of fora we'll host throughout the year, and where we invite distinguished speakers who can discuss issues relevant to population health. The idea behind these talks is that they are our monthly pause in our busy academic calendar to stop and think. So thank you all for being here, being part of today's discussion. So this is a time for extraordinary change for the American healthcare system. It seems like there hasn't been a moment in the past year when we haven't had a discussion about a healthcare law, with the Affordable Care Act seeming to be on life support, but then to live to die another day. And paradoxically, as this is going on, the possibility of the U.S. actually embracing something more sustainable and different is starting to look more real than ever, as a growing number of lawmakers, at least on one party, continue to endorse the option. Of course, we are in a continent where we have a neighbor that has adopted a very different system and has had that for quite some time. And today, we are actually going to discuss the extent to which we can learn from our neighbors, or maybe our neighbor can learn from us. And for those who know me, they also know that I actually practice medicine in Canada, so I am not without opinions on the topic. But leaving aside opinions, we actually have a real expert to talk to us today, which is Professor David Naylor. Professor Naylor is Professor of Medicine and President Emeritus of the University of Toronto. He was involved in the initiation and early governance of the Canadian Institute of Health Research. In 2003, he chaired Canada's National Advisory Committee on SARS and Public Health. This is a committee report that sparked the creation of the Public Health Agency of Canada. He's also an officer of the Order of Canada. Dr. Naylor is going to discuss what the US and Canada might have learned from each other over the past 4 decades and how these lessons relate to the future of healthcare reform on both sides of the border. We are very glad to have with us Dr. Naylor.
Thank you very much. I want to start by thanking your distinguished and dynamic dean for the invitation to join you today, and also thank members of his team who've made the logistics so smooth. They've been terrific, Sandro. As the dean has indicated, healthcare is very much a live topic in your great nation, and it's always a live topic in Canada. It never goes away. And so this issue of slow learners somehow seems appropriate to the circumstances, particularly given some of the recent debates here in the US. I will be arguing, however, that despite our neighboring geography and despite the similarities in the two nations, we have somehow managed not to learn at times from each other, and indeed there are things Canada can and should learn from the United States in terms of healthcare delivery. And these various adventures and misadventures and health policy making have not drawn the attention that they might well have drawn if we had been a little more open-minded on both sides of the border. Now, I have heard that the definition of a Canadian is an excessively apologetic, unarmed American with delayed access to universal health care. I have also heard Canada described, as shown here, as the 51st state. I accept that the cultural congruence is striking. My accent may sound very familiar. But as a brief diversion, I'm going to argue, if I can be cheeky, that what has been going on for decades is actually a reverse takeover. We have been taking over your cultural and entertainment industry for a very long time. I want you to think back, some of you may remember, Mary Pickford, star of the silent era. Mary Pickford was called America's sweetheart. She was born in Toronto. Florence Lawrence has been called America's first movie star. She was born in Hamilton, Ontario, Canada, and on it goes. And if you just glance at the screen, you see all these very familiar faces, and every one of them has serious Canadian roots. So just a reminder that we are still with you in more ways than you know. In fact, we specialize. We specialize, for reasons I don't fully understand, in goofy comedy. And these 4 worthies are such fixtures in your great country that 2 years ago, the Canadian government got desperate and issued postage stamps to try to reclaim them. So it really is a tough situation being the mouse in bed with the elephant at times. Now, I recognize that this is a bit of a challenging time. with some unusual activity in the White House. And I want you to understand that we are also strategic and empathetic. Because on TV, your designated survivor is a good, upright Canadian named Kiefer Sutherland. So there is a Canadian alternative for the White House available easily at hand. And here's another lovely, ironic footnote to all of this. Kiefer Sutherland's grandfather is Tommy Douglas, who in fact is widely regarded as the father of universal health care in Canada. So your president-in-waiting has great universal health care bona fides. And with that, let's get down to some work. I'm going to start with a bit of an overview of Canadian health care. I'll assume that you know this complex quasi-system of yours far better than I could ever know it. And I want to provide a few generalizations after that about how healthcare systems can learn from each other and why that can be very difficult at times. Then in extremely telegraphic fashion, I'm going to hit 5 areas where I think mutual learning was possible and did not occur. And these are sort of shared learning disabilities in action, and then a few conclusions. I have been reading about, writing about, and studying Canadian healthcare for, and I cringe as I say it, about 35 years now. And I don't think, despite all those years, that I ever really had a sense of the grassroots nature of the system until a couple of years ago when the Canadian government asked me to chair a federal review of healthcare policy with particular reference to innovation or its absence in Canada. And this panel, whose members are shown on the screen, worked hard with a superb secretariat from Health Canada. And the project involved the usual activities. We commissioned studies, we received reams of submissions, some superb. But the most important thing was that we traveled from coast to coast to coast, Atlantic to Pacific to Arctic. And the latter was a bit of a misfire. We somehow managed to do our tour of the 3 northern territories in the dead of winter, not recommended. But we talked to stakeholders, to patient advocates, to bureaucrats, to policymakers, to clinical leaders, right across the country. And we got a very interesting sense of Canada's healthcare system. There was extraordinary talent. There were wonderful people everywhere. And we came away with a real sense that they are the saving grace of a system with some quite flawed architecture. And the architectural flaw is pretty clear. There are variations across the provinces and territories. Just as in the US, it's at the subnational level that the primary administrative locus for healthcare occurs. Your Medicare plan is obviously an exception. And so variation is meaningful. Nonetheless, the common architecture is like something out of the 1960s. It is a highly disintegrated system. And you can have a sense of it right here if you just look at the public-private blend of funding in the system, shown on the slide. You know, pretty much 100% of the spending on physician services is through public sources. We have a strong monopsony system. For general hospitals, it's almost the same. A little bit of private revenue on the side for private rooms and amenities, but it is a universal first dollar system. Public health, of course, is publicly financed, but for the rest, there is a hodgepodge, a mix of both private and public funding, some of it insured, some of it not, with substantial interprovincial variation. And this system has another interesting wrinkle to it, because when you go back to the 1960s, when medical services insurance was introduced, about half of Canadians had some form of prepayment. It could be nonprofit, like your Blue Shield plans, or it could be for-profit insurance offered by private payers. But the key was that all of those transactions occurred on a fee per item of service basis, and this was the wide framework of private practice that prevailed. What Canadian government said was they put those plans out of business. No mercy, unlike the Affordable Care Act, they were swept away. But what we did was we replaced them with public insurance plans so that we had a system that has been called private practice and public payment. with all the usual problems. You cemented or locked in collective bargaining by health professionals focused not on their role in the system, not on their role as purchasing agents, not on their role as stewards, as team members or team leaders, but core professionals, physicians, were locked into a small business model fighting for the prices of their services. And that continues to preponderate to this day. So that disintegration is a big challenge for us that I'll come back to. There's no question we have been trying to retreat from fee-for-service private practice. And there's no question that if you think about it, we actually have a system that, despite allegations of it being socialistic, is actually quite a mix of private-public partnerships. And although there has been, as shown on this slide in the last number of years, a movement away from fee-for-service payment, it's important to emphasize this hasn't involved intermediaries like integrated delivery systems. What it's involved is shifting family physicians from a fee per item of service basis to capitated funding. And that is obviously more logical for primary care practitioners, but it still supports a system in which you have basically private practitioners. These are private operators, simply funded in a different way. Now, that has some unfortunate implications. Our equivalent of the National Academy of Medicine is the Canadian Academy of Health Sciences. A couple of years ago, it did a very large multidisciplinary study of how talent was used in Canadian healthcare across the country. And the results were really quite damning. In effect, our system fails to make proper use of a huge range of health professionals, nurse practitioners, psychologists, physical and occupational therapists, the list goes on. And by creating this private practice framework and disincenting delegation and team-based care, we have locked our system down into a model that really doesn't make sense for a modern era of chronic diseases and an aging population. It certainly is, less than helpful to the cause of addressing the broad social determinants of health. So they proposed many steps to try to make the system better for a range of health professionals, to help patients access their services, to help them realize their potential. But they emphasized that until we changed payment mechanisms and funding, till we bundled budgets, brought in some intermediaries to pull things together, we could not make progress. And so I would argue that, well, we have many strengths in Canada in our system. There are two unfortunate images that kind of sum it up, shown on the screen. The first is the field of silos. Since Canada should be a frozen field of silos, I suspect, because it is a highly disintegrated system with very poor handoffs between its segments and constant challenges in moving from community or home-based care to the institutions and back again. The second is the image of the big tap, because one thing we have done quite well is to contain costs. One of the huge advantages of a single-payer or universal system is there is the ability to squeeze down funding at source and to mitigate the amount of transactional micromanagement that I know drives many of my colleagues in American medicine crazy in their daily practices. And there is a missing image, some would say, and that is very long queues of people waiting, and I am sorry to say we have some of the longest waiting times for specialist consultations and elective surgery in the OECD. The queues for these services are prioritized and overwhelmingly. There is an effort made to move the sickest people to the head of the queues. But the waiting times are unacceptably long. This is widely realized. Now, turning the big tap works. Canada used to have the second most expensive system in the world on a per capita or GDP basis. Now we're middle of the upper quartile in the OECD because we've been tougher than many other countries with single-payer systems, and some of them, like the Netherlands, have adopted multiple payers and managed competition. We've stayed with this tougher model. And you'll notice that if you don't have a single tap that you can squeeze, if you've got streams and creeks and rivers, coalescing into one torrent after another, you end up with that unfortunate outlier at the top that you're all familiar with 16–70% of GDP going to healthcare, and still not everybody covered, and enormous misspending. So there are advantages. On the other hand, while containing costs is terrific, what we're all trying to do is to make people healthier. We want to take people who are unwell, make them better, and to take people who are healthy and keep them healthy. And here, although our spending is in the upper quartile, our overall performance is middling. Value for money is quite moderate here, not excellent. This shows a number of the indicators profiled by Canada's National Health Information Agency based on OECD data. It's scaled and indexed in an interesting way. You'll see the 25th to 75th quartile band. Most of these metrics are for care-sensitive conditions, and some are population health related. And what I think jumps off the page is we're not really particularly good at anything, with one exception, and this is fun. This one here, self-rated overall health. Canadians, if nothing else, are somewhat optimistic. Despite all the challenges of our system, we're quite convinced that we have very good overall health. So that's the good news. Ignore all the other indicators. Now, all of this, unsurprisingly, means that when the good folks at the Commonwealth Fund look at healthcare systems and they do those maddening report cards with all the indicators aggregated into a single number, always a problem, we know. But when they do that, Canada doesn't do that well. And on the one hand, our system is often beatified by American exponents of single-payer care. It's demonized by those on the far right who are opposed to any type of universality. But it's worth remembering that we are in the cellar with our great neighbors, all of you in the room, when you look at these types of rankings. This is the 2014 table. And I would just point out that Canada actually has been falling in these rankings since approximately 2003, and that many of us have been sounding alarms about the need for fundamental reforms in Canadian healthcare going back actually 20 years because of the failure to change the architecture of the system. This table, by the way, stung. It hit home and got a lot of press and a lot of political notice, and I think it was because it was the largest number of comparators, but also because something interesting happens. It's going to be relevant, I think, in the years ahead. America was on the move. After the Affordable Care Act, there was a sense that this country was gaining momentum, had its Health Care Act coming together, and more than a few Canadians said to themselves, the way we're going to be dead last. Those blasted Americans may finally leapfrog us, and we can no longer be smug and self-righteous north of the border. So it is important to understand how these perceptions play out in other nations. And by the way, in the 2017 update, Canada had a breakthrough. We snuck slightly ahead of France, and we got to 9th from 10th place, just above America. And I have to tell you, I'm dubious about that, because if you look at that, the tables and the rankings, you'll see that France goes from the top of the table, number 1 for healthy lives, to 5th in that table of 11 nations, dropping 4 spots in your overall health outcomes in the space of 3 years. Not plausible. They must have changed the measures. So I actually believe we're still in 10th place. Now, let me come back to this report. I'm not going to spend any time on it, but I just want you to have a flavor of what we said to lawmakers in Canada were the areas where Canada needed to do work. 5 areas where the federal government might partner with provinces to move things along. And they're the ones you would completely expect. I don't think there's a single one of these that would be a surprise to you. I'm not going to read them. I only want to pause to emphasize that if there was one that worried us, it was the second one. This architecture that was dysfunctional. The lack of integration is the fatal flaw in Canada's healthcare system. And the fact that the system works as well as it does is due to the extraordinary talent and commitment of the people. The architecture works against quality and continuity in a serious way. Now, you may ask, okay, if it's like us, how does the federal government actually create or catalyze integration? That's a point I'll also come back to in short order. I said there'd be some general observations. One of them, I think, is intuitive. There's no perfect healthcare system. There's no panacea. You can't import someone else's healthcare system. They're all the product of context and values and history. You can adapt, and that's about it. But the other point I would like to make is that if you look at Canadian experience, if you look at global experience, market forces are overrated. And a huge amount of what drives the best healthcare systems, I'm sorry to use the term, is implicit rationing. Concept that the great medical sociologist David Mechanic brought into play, gosh, must be 30 or 40 years ago, and which I think is apposite. Because if you don't have some implicit rationing, you will have waste, and you will also have, if not implicit rationing by availability and by medical priority, the type of implicit rationing that has bedeviled your system, and that is implicit rationing by health insurance, by income, by social status, and things that are more arbitrary and capricious. I also want to take a second to comment on a second general observation, and that is every healthcare reform involves a balance between simplicity and complexity. And here's an irony, something we might have picked up from each other. I'm going to move away and hope this lavalier mic works. Canada has two cornerstone pieces of legislation that created cost sharing and drove us to universal medical and hospital insurance. One from 57, one from 66. Cover a grand total of less than 14 pages. Here's the Affordable Care Act at 906 pages. The codicil, I call it, at another 55 pages. This is worthy of Leo Tolstoy's War and Peace, and a lot less interesting to read, by the way, if you ever tried to read this devil. It is a staggeringly complex piece of legislation. I would just say to you as a dangerous generalization that if repeal and replace is very ill-considered, very reckless, some renovation and simplification would make a lot of sense. And conversely, if you look at what Canada has, we made a fatal error. We decided to go with a simple nationalization of fee-for-service insurance plans, and we never created intermediaries to bring the pieces of the system together. So a bit more complexity, maybe even a bit more incrementalism on our part might have put us in a better position today than we are now. Now, I'm just going to come back to some of the unintended consequences of complexity. This is, again, from the Commonwealth Fund. And you try to build marketplaces, it's a tough game. And what you see here, rather depressingly, is that many of those most in need of help are those who are least likely to get it when you go this kind of subsidy and marketplace creation route. Now you also see little snippets like this. Let's ignore this giant self-inflicted wound in the middle, the fact that people are scared off by pending repeal of the Affordable Care Act, and just look at the ways people find to rationalize their decision not to participate. You know, universal health care may feel as if it's a form of compulsion. Tax-funded plans that sweep in revenue from everyone and ask us to join forces may sound as if they're somehow socialistic. But frankly, that's where most of the world has gone, and there's a reason for it. So I would just argue that universality, which is so prevalent, at least has the virtue of simplifying things. We may have oversimplified in Canada, but it does change the playing field. It certainly radically contains administrative costs. It reduces overall spending to more reasonable levels. That's very clear across the OECD. And it has a very important advantage that you see in one study after another, and that is it reduces the socioeconomic gradients in access to services. And the Affordable Care Act has done that here, but there's vast amounts of disparity that exists in America that does not exist elsewhere. Doesn't really remove these disparities, by the way. Canada still has gradients. Upper middle class Canadians, those with more education, are more likely to see specialists. Those who are less educated, less well off, more likely to rely on family doctors. This is clear. And the same pattern, by the way, emerges right across Europe. But the gradients are a lot shallower, and there are no fully dispossessed people. So I do think that we should never lose sight of universality as a goal. And I just want to add one further piece to this puzzle. Canadians have been very defensive about their system. You know, for years, as it's flagged a bit, we've tended to look south and demonize the US system. That defensiveness, I think, is partly because Medicare is part of is a fabric building part of Canada's identity. It knits people together. It gives the nation a sense of social solidarity that is so important in this atomized time of ours, when people are pushed apart from each other. I think it also signals that in what is a very competitive world, a growingly competitive world, that there are domains in a society where a collaborative and cooperative ethos prevails. Maybe a bit idealistic, a bit corny, but I have to say that these things have mattered to Canadians and underpin some of our perhaps now misplaced pride in our system. With that, let me turn to the 5 quick lessons. The first goes back well over 40 years, a shining moment for Canada. 1974, our National Minister of Health produced a new perspective on the health of Canadians, which was praised all across the world, made waves. It said, stop thinking about health as being about healthcare and start thinking about the broader determinants of health. This was really a pivotal moment in this whole movement towards social determinants. And you'll see editorial cartoonists love this because the Prime Minister at the time was Pierre Trudeau, who was quite a fit specimen, the father of our current Prime Minister. But he had a cabinet full of obese, chain-smoking drunks, and that was somewhat notorious, and so the editorial cartoonists loved this idea that his health minister was attacking diseases of lifestyle, behavioral indiscretion as causes of ill health, when the cabinet was so clearly guilty of them. Nonetheless, although the Lalonde report was widely praised, so little happened with it in our country. Academics got on board. We had a lot of collaboration with the US and UK. I'm familiar with most of the players and publications. We deepened the conceptual framework. We strengthened the base of research. The whole social determinants model was really elaborated in exciting ways. But still, from a policy perspective, from a healthcare delivery perspective, nothing happened. One province did some work on integrating frontline primary care and community and social services, Quebec. Did it through its so-called CLSS regime. Most of those were taken out of play by competitive practices by family doctors on a fee-for-service basis. So if you think of an area where we are slow learners, it's simply this, that healthcare spending is all well and good. It's important to address a whole series of issues. But if you want a healthier population, it's not the primary way forward. I think this is widely recognized. Certainly in our system, the architecture is a massive impediment. And what's interesting is that in the US, the so-called health maintenance organizations and their successors, integrated delivery systems, have much of the machinery that would make it possible to begin to think about going at these issues. Now, I would caution that focusing on a roster of patients instead of a community or a neighborhood is not going to drive population health. And so you get some interesting statements. There's this one from the CEO of Geisinger, and Geisinger is certainly an outstanding organization. But these kind of random musings where you're not sure whether the CEO is talking about home care and community care, primary prevention, or actually thinking about population health. So we've all picked up this kind of new interest in population health for academic health centers and partners, for all of these entities. It's in the right direction, folks, but it still isn't what I think we need. And just let me add that Kaiser has been spectacular. You know, Canadians should be so lucky as to have entities doing this, in terms of examining in a rigorous way how those who are invisible minorities may not get the same access to preventive services and screening, and actually following up to drive change. This is tremendously commendable. It's still in the realm of primary prevention. It's not upstream with the social determinants. And I would just say I think there's an enormous challenge and opportunities for schools of public health in the next generation to figure out how to bring these threads together. And frankly, there's no place where it can be done better than in America, because your system still has, despite all the challenges, the agility and some of the intermediaries who can actually attack these issues. Now, another one of these slow learners slides. I don't know why we are still paying physicians on a fee-for-service basis. George Bernard Shaw wrote this in 1906. It's a long sentence, but it's a wonderful British sentence that summarizes the perversity of paying physicians this way. And yet, it prevails. We know what happens when you rely excessively on fee-for-service. You can do it at the margins, you can do it for targeted incentives. I'm not saying that you do not accede to some of what drives human nature. But to have it as a core mode of paying physicians is so toxic for all the reasons shown. Volume, not value is driven. There's no focus on stewardship and quality. There's nothing to incent team-based care. It can actually disincent delegation and shared care. It doesn't reward interprofessional collaboration. It doesn't reward management and leadership. It actually tends to reinforce this silo-based model where physicians, a profession I'm proud to be part of, stand apart from the system and do not contribute to the fullness of our own potential to make it better. Now, this is something of a corollary. It's arguable, and I think literature supports it, that while America is constantly slagged for the overall expensive chaos of its healthcare system, you have subsystems in this country that are arguably the most efficient and effective in the world. And many of you will have seen the debate about the comparisons between Kaiser Permanente and the British National Health Service. The Brits were greatly offended by them. But I think they're telling. And it remains a mystery to me that Canada, sitting so close to your country, with so much access to the information, so easy to go visit these plans, to study them, has been unsuccessful in moving in this direction. It's particularly puzzling because Canada, as you know, is the birthplace of evidence-based medicine. We're always rabbiting on about the virtue of randomized trials. And this is one of the few areas where we actually have randomized evidence about health policy and structures of care. The Rand Health Insurance Experiment, this key paper in the early 1980s, very clearly delineates a comparison that's relevant. You can compare, as they did, what amounts to Canadian-style single-payer health care. First dollar coverage for physicians practicing on a fee-for-service basis, and first dollar coverage for hospital care on the in the one arm, to an HMO or integrated delivery system on the other. One somewhat less developed than those that now exist in its panoply of services. And that was the old structure of group health of Puget Sound. Data are pretty clear. Nothing compelling in the way of outcome differences. Some interesting chatter in both directions, but nothing that I personally find compelling. And a 25% savings per capita, per person, on average, for the HMO, or integrated delivery system. Why the heck one would go on with this private practice public payment model or private practice private payment model in the face of this type of evidence is all about politics. It's about ideology and values. It has nothing to do with evidence. And it is less excusable that Canada would have failed to follow suit, because we, on multiple occasions, talked about building Canadian-style HMOs. I was part of a movement in the late 1980s to do that, and the Ontario government killed it off for political reasons, even though we were in advanced planning. In 1996, again in Ontario, the agreement between the doctors and the government said, we will create an experimental made-in-Canada HMO. I helped craft that. Never happened. It's just, I could go on about the number of times we've said, we should do this. Never happened. And it's terrific you're doing it, and I believe that it could be a cornerstone for a better and perhaps even universal healthcare system here. I just want to add to this that one of the reasons this matters is to get physicians out of the pushcart vendor mode. Fortune magazine in this nation called American doctors pushcart vendors in an age of supermarkets 45 years ago. And today, a great number of Canadian and American doctors are pushcart vendors in an era of e-commerce and artificial intelligence. We need to move to a different model. So let's now forget the howdy-doody man here and all of his congeners in our professions and move to the last couple of examples. You know, one of them is that healthcare systems all over the world not only fail to learn from each other across borders, they don't learn from each other within civic limits. They don't learn from each other within state boundaries, or let alone across state boundaries. We found this very dramatically in our review of Canadian healthcare for the federal government 2 years ago. And we called it the NIH disease, the not invented here disease. Every system has to have something that will allow scaling, that will allow rigorous evaluation, that would allow these local innovations to be taken up and spread. And that ability to innovate is America's great strength. For all of the drawbacks, you have a dynamic, pluralistic system. And we have seen, tellingly in our country, that if you lose that macro architecture of pluralism, you can pay a price. Nonetheless, we do have a huge amount of micro and meso-level innovation happening, as do you. We found it years ago. A former health minister, Monique Bajen, reviewed Canadian healthcare and found it in large quantities and was baffled. Bajen said that Canada was the country of perpetual pilot projects. Couldn't figure out why we never scaled anything. And here I just want to point out that it is almost paradoxical that the most interesting exercise in catalysis, in innovation, evaluation, and scaling is in your country. I fear it may be under threat in the current political climate. Not all of you may agree, but the Center for Medicare and Medicaid Services has, as you know, an innovation center. When I examine the OECD and consider what is the model for a scaling and innovation agency, CMSIC is probably it. And you know, when I say this to my academic colleagues in Canada, they sort of snigger. It's a government skunk works, it's a sweatshop of quasi-academics, the usual dismissive stuff from the ivory tower. So a couple of years ago, listening to this guff, I did a little search. I just focused on the top-tier journals like NEJM, JAM, and Lancet. And this is a partial sampling. This is an enormously rigorous and productive agency. I acknowledge that it has a bit of an experimental forum in Medicare that lets it port things over to Medicaid. But we were very struck, in fact, we came down to visit CMI, that Canada's current stasis might well be helped if we could do this. In fact, you think your system's in crisis, ours is in stasis. That's the word that applies. So we actually a cornerstone recommendation was to create what amounts to CMI North with a reasonably sized innovation fund to seed scaling and for the federal government to work in partnership with the provinces. And the number one priority, coming back to what I said earlier, would be to focus on and catalyze meaningful integration. Last point before I wrap up. You know, federal governments in Canada, federal governments everywhere, like block grants. They don't like match funding. They like it for a short time and then they don't like it at all because it means they have to keep spending. I had the great pleasure of working with Ben Summers from Harvard on a viewpoint for JAMA just a few weeks ago, where we looked at the Republican health reforms with their reliance on block grants and examined them in the light of Canadian experience. And it is not a very pretty picture, I'm sorry to tell you. In particular, you will be familiar, much more familiar than me, with the variation by state in federal spending on Medicaid. It's a function of the baseline commitment by states, but of course it's also hugely a function of which states have participated in the Medicaid expansion with 100% coverage, now falling over time to 95 and eventually 90%. But this type of variation, twofold variation in spending, speaks to exactly what the potential damage could be. A huge amount of money will be bled out of the states through a block grant program. And let me just emphasize the points that Ben and I made. Canada did this starting in the 1970s when the federal government got tired of paying for the programs it had actually set in motion only 10 or 15 years earlier. Canada's National Medicare Act was 1968. By 1977, they were trying to walk away from it and walk away from match funding and go to block grants. The term they used and sold to the provinces was established programs funding. It's a lovely bureaucraty's turn of phrase. Programs were established. You've had our money for a few years. They're established. You don't need our money the same way anymore. We'll just give you a block fund. And the block grant will mean you can do whatever you want with the money. Provinces fell for it. And no surprise, suddenly, transfers were just another line item in the federal budget. They were toggled back. In the recession of the 90s, they were cut arbitrarily by 30% with huge pain for the provinces. And you hear the argument that somehow there will be more innovation with this kind of flexible incentive. We haven't seen it. Now, the thing to remember is that in Canada, if you cap spending, the doctors can't retreat. They can't cream skim. They get the same amount for each patient. Do that in a state, and you are inviting cream skimming, where the patients who have lower fees attached to them, Medicaid patients, are less desirable. The other thing that happens is you can't really step away from this program in Canada. It's strongly supported. I've highlighted its point in its prominence in our national psyche. You know, if a state decided that it was in its interest to focus on the affluent, to step away from funding Medicaid, to scale it back, political consequences are radically different than they are in Canada. Just segmenting the votes. In fact, segmenting it so that those who are less likely to vote are preferentially disadvantaged. This is a snare. I'm not saying block grants are always bad. They have a real place in policy in many realms, and they have been tested and can be done. But what I am hearing and reading and what Ben Summers and I wrote about is quite disquieting. And the Canadian experience, I hope, will be illuminating. So let me conclude. First, on this issue of how we measure up together, you know, we're cellar dwellers, but we're good friends and neighbors, and I can't imagine a better group of people to share a basement apartment with than my friends in America. Second point. Every time I come here, I am impressed, as always, by the amazing talent of America, its diversity, its dynamism. I think the same is true for Canada a small mirror of this great country. And I continue to believe that if we learn from each other and move forward, the talent will enable us to prevail and to make healthcare better and our citizens together healthier. I do understand that there is a tendency, as I've said, for Canadians to be smug about their system, despite the knocks we've taken, and to look south and feel slightly self-satisfied about what happens here. And I would say to you, sometimes I think that after ice hockey, Schadenfreude is our national sport. Watching the latest travails of the Affordable Care Act, I think some Canadians are almost gleeful. Most of us, however, are sorrowful. And I think that if we can get past this view of, a sort of Stalinist regime for healthcare in Canada and total chaos in the US, and understand the strengths and weaknesses of these systems, that these systems can learn from each other and move forward. There's lots of room for that. The last point I want to make is this. Canada was a healthcare Camelot in the 70s and 80s. We're pretty mediocre now, but I think we can be very good again. There's a risk that we will settle for less than very good, and certainly we're likely to settle for less than excellent. The US, whatever the travails of your long journey to universality, doesn't have to settle. It's still a work in progress, sometimes painful progress. But you have the structures and the talent, the intermediaries and the dynamism and pluralism to do something quite transformative here. If the political will is there, if the generosity of spirit is there, if there's a commitment to rebuilding social solidarity. So I remain optimistic that this amazing nation will find its way to a world-beating universal healthcare system, one that serves all of its citizens with high value of care. And the happy side effect will be that we will no longer be able to gloat north of the border, and we may finally improve our system too. Thank you for your kind attention.
So first of all, thank you. That was terrific. So can I ask a question about why Canadian healthcare is not better? So you dedicated only half a sentence to this in your whole talk, where you said it's politics and ideology and values. It's politics, values, and ideology. But given that you said that Canadians feel good about themselves because healthcare is part of the national mythology, so why are politics and ideology getting in the way? Why is Canada number 10? Why shouldn't Canada be number 1? What's stopping it?
I think the most important problem is that we have done enough to be expensive by our lights and are reluctant to extend coverage, as it would mean more public payment and further shifting the public-private mix, which is actually at the lower end of the OECD at 70-30, but many other countries are 80-20, but there's an aversion, a tax fatigue. And the result is that it's unlikely that we can buy change, so we have to fight for change. And the fight, unfortunately, is going to be one with getting organized medicine to step away from its current obsession with fees and private practice. And to make that less painful, you need intermediaries. You need to have alternatives so people can take an off-ramp out of the current siloed system to something that's more integrative and creative. And as I've said, for reasons I don't understand, Sandro, the multiple provinces have talked about doing this and none have done it. They've talked about doing it at regional level. They've never brought the physicians into the budget system. They've never brought drugs into the budget system. They leave it only partially integrated. So I have no real answer to this except a sense that it's good enough. And I also think, to some extent, it is this mythology which is reinforced whenever folks in the White House or in Congress or the Senate decide they want to repeal your Affordable Care Act. If I understood it, if I had a key 20 years ago when I started complaining about it publicly, I might have been able to do something about it. I don't really know what it is.
Actually, following up on what Sandro mentioned in terms of some of the restraining factors, politics, ideology, et cetera, economics, are there any segments in the Canadian system, or society, I should say, who are championing a more efficient system, more toward universal health care with the innovation that you're referring to, for example, more HMOs and other efficient ways of delivering? I mean, what is the status at this point of where the impetus for improvement is?
I think there is some sense on the part of the federal government that it has got a new deal with the provinces and it just wants to stand back for a little bit, unfortunately. So they're less likely to be an active catalyst. Multiple provinces continue to talk about moving in these directions. I'm skeptical because I've heard this kind of talk before. I personally think that what will drive this will be, and I'm sorry to put physicians front and center, but on this one they need to be. I think a new generation of young physicians are going to say, this is nuts. We don't see that this is a mode of practice or a mode of participating in a healthcare system that is constructive for us to use our talents. We don't want to run on the fee-for-service treadmill. And I think there will be a generational shift that will drive organized medicine to start embracing experimentation and change. But the current dynamic at the bargaining table is all about money and fees. I mediated the negotiations in 2014 in Canada's largest province. Didn't get a deal, unfortunately. It's been ugly ever since. Did a mediation in one of the other large provinces. We did get a deal there. And as a mediator, I can tell you that both sides are difficult. But there's a laser-like focus on the part of the doctors on the dollars. They're all fussed about participating, being change agents. But somehow that just kind of moves to the edge of the table. And I don't think younger physicians are going to allow that. Nurses, bless them, have been very vocal about some of these issues. And, it leads to a certain amount of interprofessional tension at times. So have other health professionals who say, why aren't we insured? So I'm cautiously optimistic that in the next 10 years, we're going to see an attempt to reinsert consolidating intermediaries that will do bundled payment, that will do some of the innovations that are part of your scene today, some of which may go all the way to full integrated delivery systems with aggregate budgets. Until we do that, it will be hard to break the gridlock. My belief is once we have a few of those, it's going to be a stampede. People want to be part of them, both providers and patients, and we are going to see a massive shift take place. And I'm hoping it's before I'm carried off somewhere. But, and I have a lot of faith in the next generation.
Hello. I'd like to start off by saying I really appreciate you saying that America has this innovative capacity that makes it kind of in a different playing field from other countries that are currently innovating their systems. I don't hear that very often, and it's honestly flattering, motivational. But I kind of see a pattern from when I've been abroad in which people will say that about America, and I don't see that. And I don't maybe think the nation as a whole understands or appreciates how innovative the structure can be if we use it in the right way. So just like you said, that's entirely true. But thinking about it compared to like state sovereignty, federal government's influence, local, officials and municipalities, how can these smaller organizations of government actually create a system that's single payer or universal when the federal government is so opposed to what's going on? And if that's possible, how do we make it possible?
Tough question. there's several caveats. The first is I hear my late mother calling to me from heaven and saying, David, when you're in someone else's home, don't tell them how to rearrange the furniture. So I will be careful. The second is it's not entirely clear to me that the current bizarreness is dispositive in terms of understanding why these problems have occurred. The Supreme Court decision on states' right to opt out is pretty dramatic. And that wasn't the federal government that drove that. So I think that there will have to be some new narrative where that, and it may never happen, but that Supreme Court decision is a huge issue in terms of driving to universality in your current structure. Now in Canada, provinces could have opted out. But when they were offered a chance to have vast numbers of people covered who weren't covered and a lot of money, they all opted in. So getting there is clearly tougher in America. It's a vast, sprawling, almost ungovernable place with a lot of diversity. I don't have a magic bullet. I do believe that it's going to take some renewed and different relationship between the center and the periphery, between the federal government and state lawmakers to drive this in the right direction. And I am flummoxed to provide a prescription given that Supreme Court decision. If there's one thing I could do, I'd reach in, I'd turn that back, because that was critical. It means that if you have an administration that is actually determined to drive forward, to go up incrementally from the Medicaid expansion, to begin to generalize, that would want to see the various demonstrations under, CMS Innovation Center's work, generalized not just to Medicare, but to Medicaid on a mandatory basis, things that, frankly, make some sense. You can't do them. So I don't have a magic bullet, obviously, and if I had one, I would be suspect because I'm a Canadian and we're not very good at bullets. We're unarmed, remember.
Thank you, Dr. Naylor, for that very engaging presentation. I'm a recent transplant from Toronto and at U of T alum. And when Americans ask me about OHIP, I like to explain that it covers everything that's medically necessary as long as you don't consider your eyes, your teeth, or your prescriptions to be medically necessary. And I wonder if you could speak a little bit to where that fragmentation comes from in the Canadian healthcare system, why certain disciplines are sort of divided from the way that we provide care, and whether there's any lessons that we can take from the states to kind of overcome those divisions, or alternately whether as the states hopefully moves towards a more universal system, any lessons they can take from us to prevent that.
That's a fabulous question. It's very interesting that if you study the pre-Medicare debates that occurred in the 1940s, Canada was contemplating medical services insurance that would cover a range of professions. And that was actively debated in House committees. What really seemed to be the driver is that the penetration of nonprofit and for-profit insurance in the medical marketplace was so large, even though as many as half of Canadians were not insured or very limited insurance, it was clearly a precedent, there was clearly a pattern, and it was given the centrality of that as a public issue at the time. That was a very tempting political target. It was the low-hanging fruit, as it were. And what encourages me thinking about the states is that Medicaid covers a lot more than Canadian healthcare. It is a more expansive program. So America's already, gone beyond where we are with that program. I think if you were to redo Canadian healthcare, you would certainly, at minimum, provide dental coverage for low-income and elderly. You would certainly provide some core optometric services. You would not have psychologists excluded from providing mental health. They're not an insured service in most provinces. What is really almost scandalous is that in an era of an aging population, when so much of modern healthcare is rehabilitation, Canada generally doesn't insure physical and occupational therapy. And again, a lot of this is done better in the US. So I do think that the way for us to make this affordable is back to the theme of integrated delivery systems. In the late 80s, when we were costing out an HMO for Canada, we had all of that baked in. We had modes whereby as you achieve savings, you would plow them back in to extend coverage. The 25% margin was obvious. We just say, hey, look at the randomized evidence. If we can save 15% by going away from this crazy fee-for-service model, we can plow it back in to get more subscribers by offering them more services. And I will say, looking at America, with 16, 17% of GDP going to healthcare, it's almost unthinkable that you couldn't cover everything for everybody. So I'm an optimist, but as I said, Canadians are optimistic. Even when our health statistics are rotten, we're very happy and say we're healthy.
Thank you. There are a bunch of countries today where the private sector, whether it's private delivery systems or private insurance companies, are operating in parallel with weak public systems. And many of those countries are struggling to get from where they are today to universal health coverage. Canada decided to wipe out the private insurance system. Do you think the countries that are struggling with this issue today can get to universal health coverage without wiping out that private sector?
That's such a tough question. I'm going to suggest that it may, a terrible answer, it may depend. I think the context is critical as to when and whether one can take that kind of bold step. So we're back to ideology, values, and politics. It also depends upon who is uninsured and how large that pool is, and who's going to be displaced, and how influential those adverse interests are, or adversely affected interests are. So the Canadian decision was critical and quite at odds with what emerged elsewhere. Just to say, well, there are countries such as those you highlight, David. There are also places across Europe where there are strong universal systems, and there's a small sliver of parallel private insurance. It is regulated, contained, constrained. Canada went so far as to basically you say you can't even have that. Canada is one of the only countries, perhaps the only country in the OECD, where you cannot have private insurance for publicly insured service. This is extreme. Many of us think it's actually a bit nuts. So I do think that those countries will have to grapple with and confront the private insurers. They're going to have to, if they're going to keep them, they're going to have to regulate them in very stringent ways that sharply cut their profit margins and maneuverability. To some extent, that's what the Netherlands has done. There's a template benefit plan. There's real constraints. Germany, as you know, is not exactly the same, but there's some of the same flavor of constraint in what is allowable. But I think that unless you either wipe them out or constrain them radically, you can't grow the public system. Just can't do it. So largely, yes, I agree with your hypothesis, but I think it's going to be very tough to decide country by country just what its political feasibility is, and some compromises on aggressive regulation may need to take the place of some sweeping legislation. Can we close this curtain for this individual who's being blinded before she speaks?
I have a question and I'm being blinded.
The heavens are sending a signal to you. You're being transfixed. You're going to say something very profound.
I'm a fellow Canadian. For the last 5 years, I've been working in quality improvement in primary health care in British Columbia, in Vancouver. And I really relate to the statement that Canada is a country of pilot projects, and we have many just within the province of British Columbia where the ideas aren't necessarily getting transmitted from one place to another. And I'm curious to hear from your perspective, what are some of the pilot projects that really should be scaled up and spread out across Canada or across borders as well?
So in the interest of time, I'm going to, because we're over time, there's a whole section of the 2015 advisory panel report that sets out a number of the pilot projects that are particularly praiseworthy and interesting and scalable. And it's a very partial list, but it will give you a flavor of what we saw, and it is set out there for exactly the reason you asked, like what are the examples? They're there. And if you are busy, send me an email. I'll extract the pages from the report and email them. It's a full service post-presidency.
Thank you.
I think we're going to stop now to have time for some informal conversation over some drinks. Please join me in thanking Dr. Naylor.
Thank you.